All right. Thank you for joining us, everyone. We are very excited for our weekly Emory Department of Medicine Grand Rounds. And we are particularly excited to be joined by one of our own, Dr. Justin Cheeley. Dr. Cheeley was born in Atlanta and raised in Gwinnett County, Georgia. He graduated summa cum laude from the University of Georgia with a Bachelor of Science in Biology before earning his medical degree from the Medical College of Georgia in Augusta. He then completed his internal medicine residency here at Emory from 2010 to 2013 before serving as a chief resident the following year. He then went on to complete his dermatology residency here as well and also served as a chief resident in his third year. Since 2017, Dr. Cheeley has been an assistant professor of dermatology and general internal medicine at Grady. His clinical practice encompasses general and complex medical dermatology, procedural dermatology, and notably 7 years as Georgia's only dermatology hospitalist, specializing in inpatient consultative dermatology. He also continues to practice inpatient medicine at Grady Memorial Hospital for 6 weeks each year. And speaking from personal experience, we at EUH really appreciate the opportunity to learn from Dr. Cheeley's expertise on the derm consult service all the time. I was just telling my team yesterday how much I always learn something from him. And with that, we can go ahead and get started. Thank you, Dr. Cheeley.
All right, thanks so much for having me, Annie. Sorry about the mishap here. Can everybody see my screen and hear me okay? Okay, excellent. Well, I'm presenting live in the hallway. It's the most secure location I could find. Um, so thanks for joining. Thanks for taking out time from your busy day and busy schedule of patient care to join us today. So my presentation today is going to be from surface to system, dermatologic presentations that change management, basically like a 4-case CPC that I'm going to be sharing with you guys. So hopefully it'll be insightful. I learned a lot from these cases. These were both all impactful for me. I have no conflicts of interest to declare financially. Here are our learning objectives that I'll just kind of skip past because they will give away the answers and some of the nomenclature there. So we're going to go case by case. This is meant to be kind of a little bit pseudo interactive. I have Zoom and the chat kind of pulled up. So feel free to chime in over Zoom on the chat if you have any comments or questions. All right, here we go. So case one. So a little teaser of what you're going to be seeing. Sorry, this is for during lunchtime. Not my fault. All right, so this patient, she is a 62-year-old female. She has a history of stage 3 CKD, type 2 diabetes, and hypertension. And she presented to an outside hospital before arriving at Emory with facial droop after having a fall. She had a CT neck and CT angiogram of the head that with contrast that showed a left MCA occlusion. And then about 5 days after that CT head and neck with contrast, she developed a bullous eruption that was tender. It started on her face or on her eyes, and then it spread onto both of her upper extremities. Since she had this kind of new sort of blistering eruption on her upper arm, she underwent CT with contrast of both arms as well, prior to transfer over to Emory University Hospital. When she arrived here, these were some of her admission labs. So her creatinine was 3.9, had a mild leukocytosis with a left shift. She was anemic, normal platelet count. And then her cardiolipin and antiphosphatidylserine IgM were both positive. Her antithrombin 3 was normal, fibrinogen elevated, and D-dimers were elevated up to 16,000. And notably, she was transferred over to the hospital to Emory with concerns for catastrophic antiphospholipid syndrome, given these labs. All right, so now we'll get to the good part, at least in my opinion, the skin exam. So we'll take a look at her skin, her presentation. So this is what she looked like when she came into Emory. You can see these kind of massive periorbital edema with some purpuric kind of bulla, hemorrhagic bulla on her face, as well as on her neck. There's kind of a side view. Kind of zooming in here, you can see that these are tense, sort of serohemorrhagic filled bulla on these erythematous bases, these erythematous plaques. And she has a lot of like heme crusting and erosions around her eyelids. On her neck, she has similar like vesicles and bullae coalescing into larger bullae on her lateral neck. And then on her thigh, she has these kind of purpuric sort of plaques with kind of linear configuration from before she was restrained. She was transferred to the 5E ICU. Before she was restrained, she was scratching herself, and this is where she had scratched. And this is one day later where she's starting to develop more like vesiculation within these bullae. All right. So here you are. You've seen the case. Which of the following would you do next? Is it obtain a punch biopsy for light microscopy? Is it obtain a punch biopsy for direct immunofluorescence, also known as DIF? Should you check ANCA profile antibodies? Begin a high standard heparin drip? Again, remember, she was transferred over because of concern for antiphospholipid antibody syndrome. Would you obtain fungal blood cultures and begin amphotericin? Would you get a CT chest and CT sinuses with and without contrast? So think about what you would do. All right. So the correct answers here are A, B, and C. So that's what we did. So we got a punch biopsy of her skin. Here's the light microscopy view. You can see that there's a lot of sort of busyness up here, kind of in the superficial dermis. These like little red specks that you might make out, that's blood, so red blood cells. So that's why we're seeing purpura on exam, because she does have some red blood cell extravasation. And then we're zooming in a little bit closer to this infiltrate in the superficial dermis. And I don't expect you guys to be pathologists, but here's what the pathologist showed or saw a small vessel vasculitis, saw thrombotic vasculopathy, and then also curiously these cryptococcoid bodies characterized here. So these little nucleated sort of cells with this kind of vacuolated appearance surrounding it. So these are called cryptococcoid bodies within the inflammatory infiltrate. All right, her DIF, her direct immunofluorescence, which we commonly obtain for workup of vasculitis or autoimmune blistering disease to highlight immunoreactants in the skin, that was negative. Her cryoglobulins were negative. Antihistone was positive. P-ANCA was markedly positive at a titer of 1 to 1,280. And her anti-myeloperoxidase antibody was also positive at 51. All right, so now we have more data. What is the next best step in management? Is it A, obtain serum iodine levels? Is it B, give rituximab 1 gram? Is it C, obtain fungal blood cultures and begin amphotericin? Or is it D, obtain a CT chest and sinuses with and without contrast? So think about what you would do. All right, so the correct answer is A, obtain serum iodine levels. So serum iodine levels were collected eventually. It took some time because it's a send out test, but 5 days after onset of her rash, and it was markedly elevated, almost 48,000. Normal is less than 92 micrograms per liter. Um, she was treated with intravenous glucocorticoids, topical corticosteroids, and then she was also on renal replacement therapy, and slowly her condition improved. So this is a case of iododerma. So iododerma is a halogenoderma. So remember in your periodic table, you have the halogen column. Those are kind of fluoride, bromide, chloride, and iodine. And those are things that can trigger these sorts of skin eruptions. Iodine, where is it found? Well, most commonly, as in this case, we saw it in the intravenous contrast that she got for a workup of her stroke. But it can also be seen in povidone iodine for an antiseptic, as well as amiodarone. So iododerma can have this kind of acute bullous presentation where you have these kind of tense serohemorrhagic filled bullae on sort of particular areas of predominance like the neck, the face, the hands, skin folds. So anywhere there's a lot of like sebaceous glands, you see more prominence of iodine excretion. You can see here this patient has these kind of necrotic plaques on her tongue, kind of these confluent bulla overlying erythematous plaques around her circumferential neck and her upper chest. Here's her elbow, again, sort of these tense bulla overlying these plaques with some erosions over her hands, fingers. And then what we saw in this case that I presented, the woman with the stroke, as well as in some of the other cases, is this thing called cryptococcoid neutrophilic dermatosis, or CND. And basically, this is something that was pretty recently characterized back in 2013 in association with Sweet syndrome. But it's this pattern where you have these degenerated neutrophils that look like cryptococcus. They don't stain like cryptococcus does. And the degree of severity of cryptococcoid neutrophilic dermatosis doesn't necessarily correlate with the clinical severity of what you're seeing histologically. Side note, I did encounter a patient like this at Grady who was presented and thought that she had disseminated cryptococcus, treated with amphotericin, got multiple scans, multiple serologies that were negative for cryptococcal antigen. She ended up passing away. And hindsight, looking back, like this is exactly what she had. She had acute bullous iododerma with this cryptococcoid neutrophilic dermatosis. So the pathophysiology, uncertain, but think that iodine is provocative of neutrophil dysfunction and apoptosis. CKD or impaired renal clearance is definitely a risk factor. And we also think that hydralazine might potentiate this kind of loss of self-tolerance and autoimmune reactivity. And we do see in sort of a series of these patients elevated p-ANCA with elevated anti-MPO antibodies as well. And the way that you diagnose it is through serum iodine levels, which is a send-out test. Usually takes a couple days to come back. It has to be drawn in a certain way. But elevated serum iodine levels 2 days post-exposure are considered pathologic. So here's another patient at Emory with acute bullous iododerma, a little bit more of a mild presentation. This is one that we kind of were able to pick up on a little bit earlier. And she had this kind of plaque on her dorsal hand, which looks a lot like clinically and histologically looks like sweet syndrome or acute febrile neutrophilic dermatosis, in that it has abrupt onset, has a prominent like facial and mucocutaneous predilection. There are dense neutrophilic infiltrates. You can see cryptococcoid neutrophilic dermatosis in both entities. However, sweet syndrome tends to be accompanied by fever. That's the non-eponymous name. That's acute febrile neutrophilic dermatosis. So it always presents with fever, usually, and fever, pyrexia are pretty rare in cryptococcoid neutrophilic dermatosis. So how to differentiate bullous iododerma from ANCA-associated vasculitis? They can be challenging because they look, vasculitic. Histologically, you can see vasculitis like we saw in our first patient case, and they can both have these elevated p-ANCA and anti-MPO antibodies, and hydralazine seems to be in the mix in some of these patients too, maybe potentiating this inflammatory process. The other thing that's challenging is iododerma. One of the risk factors is compromised renal function, and a lot of these patients have advanced CKD or are on dialysis, and so evaluation of their urine microscopy can be really challenging with advanced CKD or ESRD. So that's another pitfall. And then the other thing that is a pitfall, which is something that I've encountered personally, my mistake is that you can go through a hunt looking for sort of vascular or, excuse me, visceral beds of vasculitis, and you start to image these patients with contrast. So you image their sinuses, you image their chest, abdomen, pelvis. All the while, you can fully exacerbate and feed the acute bullous iododerma, causing clinical deterioration. So you just want to be mindful of that. But facial predominance, these kind of erythematous plaques, kind of think about bullous iododerma, and then it can devolve into what looks like pyoderma gangrenosum too, with these kind of vegetative, like ulcerated plaques that you can see here on this woman's medial thigh. So acute bullous iododerma, to wrap it up, rapidly progressive facial predominant eruption, most commonly seen in patients with compromised renal function. Histopathology can show cryptococcoid neutrophilic dermatosis. Serum iodine levels are diagnostic. So elevations 2 days after they've received iodine are diagnostic. Treatment still not standardized, but you want to avoid further iodine exposure. You want to try and promote iodine excretion. So if they are ESRD, you want to dialyze them. And then because it is related to dysfunction of their innate immune system, glucocorticoids, topical and systemic, can also help reduce the inflammatory response. Okay, so that was case one. And there's a question in the chat, is the p-ANCA elevated beforehand or as a part of the reaction? Yeah, it seems like it's something that comes about with the reaction. So when these patients present to the hospital and they get tested for ANCA serologies, they can have P-ANCA and MPO positivity at that time. I'm not aware of any brand specific sort of correlation there, but just some patients have reduced clearance of iodine and have this abrupt and really profound immunological reaction to iodine. All right, so I'm going to, whoops, sorry, move on back to case 2. All right, here's case 2. So this is a 41-year-old male, has a history of alcohol use disorder, and he presented to Midtown from Neighboring Hospital for a 2-week history of worsening tender bilateral ankle swelling. He also had swelling in his wrists, multiple joints. He was treated in the outside hospital with antibiotics, steroids, and did not get any relief with the symptoms. He reported only mild epigastric pain. He also said kind of a poor appetite. He was unable to ambulate because of this these like polyarticular arthralgias. On presentation, he was febrile up to 39, and he did have these kind of tender ankle effusions, nodules and plaques on his shins, his wrist, as well as along like intraphalangeal joints, metacarpal phalangeal joints as well. His admission lab showed an elevated CRP and ESR. He had a leukocytosis, and then his serum lipase was elevated up to 231. All right, so here's a picture of his hand. His left hand, you can see this kind of effusion, erythema, and edema of his metacarpal phalangeal joint. Here's kind of another view, kind of more of a dorsal view. You can see that digit is edematous and inflamed. And then the teaser image that I showed at the present start of this case, you got this kind of like tumefactive, very swollen erythematous plaque on his distal forearm right around his wrist. You can see it starting to peel a little bit. And then on his shins, you have these kind of nodular erythematous sort of plaques that don't photograph too well, but hopefully you can make out some of the sort of nodular erythema on his bilateral shins. And then here's some kind of nodular erythema on his knee as well. And then some other pictures around his ankles. You can see the positive Band-Aid sign, so something happened right there that we'll get to. And he was tapped, so he did undergo an arthrocentesis. And here's a picture of the arthrocentesis tube. So you can see this kind of like brown, yellow, sort of oily, turbid fluid that's had many WBCs, no crystals, and multiple joints were tapped, and none of them grew even after 14 days. Had an elevated LDH and normal glucose, by the way, as well. So underwent cross-sectional imaging of his wrist. So here's the MRI of his wrist and forearm, which showed this like phlegmon and multiloculated sort of fluid collection concerning for abscess. There in that T2 weighted image. He also had maybe some radiographic evidence concerning for osteomyelitis. His CT abdomen, you can see there. You don't have to be a radiologist to kind of see this big old goober here. This is a pancreatic pseudocyst, so he had a very, very large pancreatic pseudocyst there in his abdomen. And it goes along with the elevated serum lipase that he came in with. And then these nodules on his shins were biopsied. And so here's some representative skin biopsies of his shins. So you can see kind of down deep in the fat layer, there's a lot of action, a lot of blue. So shouldn't really see blue, should just see these white sort of vacuolated spaces with the adipocytes. And what was seen here is this lobular, predominantly neutrophilic inflammatory infiltrate down the fat. So fat inflammation, panniculitis. And we saw these characteristic ghost adipocytes or ghost cells, where these kind of remnants of adipocytes are no longer nucleated. They have this kind of stippled, sort of bluish basophilic material inside of them. And then they have this kind of thicker rim around them as well with this kind of surrounding predominantly neutrophilic infiltrate. All right, so here we're just going to go straight. What is the diagnosis? Is it A, septic arthritis and panniculitis? Is it B, erythema nodosum? Is it C, foreign body granuloma? Is it D, pancreatic panniculitis? Or is it E, alpha-1 antitrypsin deficiency associated panniculitis? So give you some time to think about that. All right, got a couple of folks in the chat answering, so good. So most of you got it right. So this is pancreatic panniculitis. So this is a condition known as pancreatic panniculitis and polyarthritis, or PPP. So this is a really rare condition. It occurs in maybe like 2 to 3% of patients with pancreatitis or pancreatic disease. Most commonly associated with acute or chronic pancreatitis, either from alcohol abuse, cholelithiasis, but it can be seen in pancreatic cancer, and usually it's acinar cell carcinoma of the pancreas. And we'll see a case, an image next slide, of a case of sort of a cult acinar cell pancreatic carcinoma who initially presented with pancreatic panniculitis and polyarthritis. The pathophysiology of PPP is thought to be hematogenous dissemination of pancreatic enzymes leading to fat necrosis, and then also osteonecrosis, chondronecrosis, which causes the polyarthritis. There is a lag time between sort of onset of these extra pancreatic symptoms and their pancreatitis, usually about 10 days or so. So a little bit of a lag there. As we saw in arthrocentesis, there can be this viscous, either inflammatory or non-inflammatory sort of oily material. You want to differentiate, of course, from septic arthritis, crystalline arthritis, um, inflammatory arthritis like rheumatoid arthritis, and these plaques can also mimic other reactive paniculitides, most notably erythema nodosum. Um, so there's a close mimic there with the polyarthritis that you can see with EN, as well as these kind of nodular paniculitides on the lower extremities. However, looking at this case, and in some other cases, you'll see that unlike erythema nodosum, which does not ulcerate, does not have surface changes, this can ulcerate. So this can cause some sort of breakdown and erosions on the skin. So here's another case of pancreatic panniculitis and polyarthritis syndrome. This was actually in a patient who was incidentally discovered to have metastatic acinar cell carcinoma. So this was almost like a perineoplastic presentation of her occult acinar cell carcinoma, completely devoid of any abdominal pain, and her lipase was like undetectably high. It's kind of through the roof. So you can see this kind of nodular erythematous uh, swellings there, kind of overlying the great toe as well. Some image and skin of color tends to be a little bit more hyperpigmented, a little bit more kind of dusky in color, the bilateral shins. Here's a gentleman with pancreatic panniculitis, maybe associated with GLP-1 agonist. He was worked up and down for cholelithiasis, MRCP, and whatnot. Didn't drink alcohol, couldn't find any other trigger, but he had been on a GLP-1 agonist and developed pancreatic panniculitis. And again, he kind of had this ulceration on the skin surface, which you don't see with erythema nodosum. So this is one of those diagnoses where histologically the dermatopathologist can actually almost line diagnosis, like name what's going on here, by virtue of these ghost cells or ghost epidocytes, which, like we said, are sort of anucleate adipocytes with thickened walls. So you can see this kind of bright eosinophilic wall, and then this kind of basophilic kind of calcification, this kind of stippling that's within the adipocytes. Elevated serum lipase is usually seen. You can have radiographic evidence of pancreatitis as well, that can sort of add to the diagnostic workup. But this is something that mimics a lot of other conditions, and there's certainly a delay in diagnosis, and it unfortunately has a pretty high mortality rate of 24% as well. So supportive care, NSAIDs, maybe prednisone, and then sort of treating the underlying pancreatitis are the mainstays of treatment for pancreatic panniculitis and polyarthritis. All right. So that was case number 2. All right, so we'll move on to case number 3. All right, so this is the 33-year-old female. She presented to EUH with a 1-day history of rapidly progressing painful racemose purpura involving her chest, shoulders, arms, back, buttocks, and thighs. So we'll take a little closer look. Here's a picture of her phone. So this is a picture that she had taken about a day prior to presentation. So this is how she looked one day previous, and then when she showed up in the ICU here, this is what she looked like. So very rapidly progressive purpura. And we say racemose because it has these kind of like jagged edges, a little bit of these like broken net-like configurations here. So indicative of potential like vascular damage. You can see that she has purpura on her lateral face, her neck, her pinna, so the external ear, as well as these purpuric plaques on her thigh. This is her right lateral kind of hip thigh area. Um, so her story is that she was previously admitted about 3, 4 days ago because of bloody diarrhea. So at that previous hospitalization, she had a colonoscopy, had ulcerations from the sigmoid colon down to the anal verge, um, had chronic active colitis proctitis on histopathology, diagnosed with ulcerative colitis. She was started on high-dose IV corticosteroids and then subsequently on prednisone 60, and she was discharged on prednisone 60 milligrams a day. But despite corticosteroids, she continued to have about 9 episodes of hematochezia, bloody diarrhea per day, sometimes with blood clots. All right, so a couple of our labs, because labs here are important when you're dealing with a purpuric eruption. So she did have a leukocytosis. Her hemoglobin was normal, platelets normal, had a mild prolongation of her INR and PT. Fibrinogen was normal. Her antithrombin 3 level was low, so 80% of normal. D-dimers were very high, so 51,000. We'll look at some of her clotting assays. Clotting assays were unremarkable, as well as her um, serologies for antiphospholipid antibody syndrome. All of those were negative. Factor V Leiden, prothrombin gene mutation, paroxysmal nocturnal hemoglobinuria testing, ANA, ENA, cryoglobulins, rheumatoid factor, urine toxicology. All of those were negative. So largely negative sort of hypercoagulable workup and autoimmune workup. So she did undergo imaging. We were suspicious for some sort of clotting disorder in the skin, so looking for clotting elsewhere. So she had a CT chest, abdomen, pelvis. Didn't have any evidence of visceral thromboembolism. She had Doppler extremities, no DVT. An MRI of her brain, no ischemic or embolic phenomenon that was seen. She had a transesophageal echo, so didn't have any like endocardial masses, no clots. So again, sort of rapidly progressive. One day prior to presentation, started developing this painful eruption on her chest, and then she shows up looking like this. So kind of additional views of her skin, upper chest, breasts, uh, arms. You can see this kind of racemose purpuric plaques, and she was in agony. Like this was exquisitely painful. She was kind of writhing in bed, very uncomfortable. Um, she had a little bit of some purpura on her gingiva here, but oral mucosa was largely unremarkable. And then just widespread purpura. Here's the positive gentian violet pen sign. So we did end up biopsying her. And here's the band-aids from the biopsy. You can see kind of her backside. So she has this purpuric eruption starting to look kind of like more dense and dusky on her buttocks. Um, Not a lot of acral predominant purpura. So like her hand, her fingertips were largely spared, just some minimal purpura here and there, minimal purpura on the dorsum of her foot, but then you can see here her toes were unaffected. And then on histopathology, um, so kind of zooming in a little bit, we're seeing some bland thrombi. So here, this kind of amorphous bubblegum material here, that's a thrombus. There's another thrombus here. Here's kind of a sweat duct. Here's an intact blood vessel. So did see some uh, thrombi within her blood vessels on skin biopsy. So, given all this, what is your next best step in management? Is it A, administer tranexamic acid? Is it B, obtain blood cultures and administer IV vancomycin? C, give IV methylprednisolone at 1 mg per kg per day? Is it obtain urinalysis and urine microscopy? Or is it E, administer high standard heparin drip? So got One person answering B, blood cultures, broad spectrum antibiotics. One person answering C, um, giving IV methylprednisolone. Anybody else? All right, so remember she was having, 9 bloody bowel movements prior to presentation, was just diagnosed with ulcerative colitis, and she was developing this purpuric eruption despite being on prednisone 60 milligrams. And, she was around like 60, 70 kilograms. So the answer here, with a little bit of some hesitation, was administer high standard heparin drip. So she was heparinized. You can see here on the left, this is the before, and this is like a day into heparin. So notably, her skin pain significantly improved after being heparinized. And you can see that these kind of active, deeply violaceous border, you can see that it's starting to recede. She does have some sort of bulla formation from where the skin's kind of infarcted and the epidermis is kind of lifting off. But she very rapidly developed improvement in her pain and then recession of the purpura that was kind of scattered on her. So here's her thigh, and then this is about like 2 or 3 days into heparinization where the purpura is starting to recede a little bit. You can see here on her posterior shoulders and upper back, the purpura is receding as well. This is even further in where the purpura is kind of fading. So we're able to salvage a good amount of her skin. And then looking at her chest, this is what her upper chest looked like. Again, had some bulla and vesicle formation from where the has some superficial infarction of the skin, but largely did really well with heparinization. And she showed up in my clinic about 5 days after hospital discharge. Um, of course, without any anticoagulation. So I had to write for that prescription. But here's her upper chest 5 days after hospital discharge. And you can see that she just has a little bit of some hyperpigmentation, a little bit of some erosions. And then you can see here on her arm, she still has some erosions there. So marked contrast, marked difference in her skin. So she has what's called thrombotic vasculopathy or cutaneous gangrene and ulcerative colitis. And we'll talk about that shortly. But notably, this patient required multiple antithrombin boluses while she was on the high standard heparin drip because she had a subparatherapeutic anti-10A level, low antithrombin levels. While on heparin, I think looking back might have been a better idea to give her bivalirudin to kind of bypass that. But she did require a lot of antithrombin boluses. Despite anticoagulation, and despite having 9 bloody bowel movements a day, she didn't have any worsening of her gastrointestinal blood losses. And eventually, she was put on infliximab, given a dose of infliximab while in the hospital at Emory, and she had improvement in her stool frequency. So, thrombotic vasculopathy in UC is rare, it's poorly understood, most commonly seen in ulcerative colitis, but it has been identified or described in patients with Crohn's as well. We think it's a multifactorial hypercoagulable state, maybe endothelial dysfunction, inflammation, elevation of procoagulants, depletion of anticoagulants, in particular antithrombin, as in this case. And we think that potentially antithrombin may be lost through a damaged enteric barrier. So there are some studies showing elevated levels of antithrombin in the stool of some of these patients. So it may be just kind of an enteric loss of antithrombin leading to a hypercoagulable state. Here's another case from Grady that was published from some of my colleagues of the same process, thrombotic vasculopathy and ulcerative colitis. So take home here is suspect this in a patient with known or even like symptoms or signs concerning for IBD who presents with rapidly progressive purpura and skin pain. Despite having impaired mucosal barrier in their GI tract and maybe hematochezia, don't hesitate to anticoagulate these patients. And then usually they require some additional modalities to better control their IBD. Like this patient that we presented, she was still having bloody bowel movements despite high dose prednisone, so she was given infliximab to better control her UC, and then her condition improved. Okay, so that was case number 3. And then we'll move on to case number 4, our final one. All right, so this was a 21-year-old female. She has a history of PTSD, menorrhagia, iron deficiency anemia, and she was brought to Midtown by her family for progressive weakness and multiple ground level falls over the previous week. Her family, was able to talk for her because she was not the best historian. She was still kind of confused, but family said that she had some intermittent blurred vision. She was slurring her speech. She was having some personality changes, kind of becoming a little more sort of childlike, infantile. And then she had like poor sort of decision-making ability, and poor sort of self-control. And then over this time, when she had these kind of neuropsychiatric derangements, she also developed this strikingly peritic and what we call ichthyotic or dry kind of papular eruption involving her face, trunk, buttocks, extremities. And this had been slowly progressing and worsening over the preceding 8 months. So taking a little zoomed in look, you can see this kind of dry scale on her forehead, her temples, around her eyelids, some increased like skin linearity. You can see on her chest this kind of flaky, ichthyotic, dry, lusterless looking skin on her central chest. Um, Also had similar findings on the dorsum of her hands, her fingers. Again, like multiple kind of hyperlinear skin creases that can be appreciated here. Palms relatively spare, so they didn't have like a thick palmar surface. And then she did have a little bit of some maybe, maceration or sparing within her axillary vault, but everywhere else there's that sort of ichthyotic papular eruption with the accentuated skin lines and creases. Here's her thigh, kind of a little bit more of a grayish silvery hue, and just very striking like perifollicular, kind of discrete papules there. Has similar findings here on her abdomen, kind of follicular prominence, and then each of the hair follicles had a little bit of like this kind of grayish, appearance to it. And then these were her backside findings. So on her buttocks, pretty well demarcated, sort of off to the periphery, these kind of perifollicular ichthyotic papules kind of confluent over her entire like dorsal um, arm, elbow, forearm area. And then, a little bit of some sparing underneath where her hospital ID was. So the other thing that was notable, that the family kind of brought to our attention was that they noticed that her breath and her body odor had like this weird smell to it. So axilla, oral cavity had this abnormal smell. And then while interviewing the family, they kind of offhandedly said that she had been consuming toilet bowl deodorizer for the previous 2 years. Um, so that was just a side note. She did present and had undergone biopsies by an outside dermatologist, and it showed psoriasiform acanthosis with parakeratosis and some dyskeratosis. So we'll zoom in there. So you can see here that the epidermis is kind of thickened. So we call that, acanthosis. We can see that the stratum corneum layer is a little bit thickened. There is some retention of nuclei. That's what we call parakeratosis. And then up here superficially, you can see these little red kind of dyskeratotic keratinocytes. So some sort of like, injury pattern there. And her outside biopsy before she came to Midtown was read as the following. So they said papillated psoriasiform dermatitis with prominent parakeratosis. And then they gave a diagnosis within their line diagnosis. So they said consistent with erythrokeratodermia progressiva symmetrica. And that was on her upper arm as well as on her thigh. So similar findings on both. So given that clinical information, what is your best next step in management? Is it A, refer the patient to genetics? Is it B, obtain ovarian ultrasonography? Is it C, obtain serum paradichlorobenzene levels? Is it D, administer oral acitretin, an oral retinoid, 25 milligrams daily? Or is it E, apply triamcinolone ointment, 0.1% twice daily? All right, so getting a couple of C's. Very good. Yeah, so the correct answer is obtain a serum paradichlorobenzene level, PDCB. So this patient's level was markedly elevated. So it was greater
Yeah.
than zero point 0.5. The upper limit of normal is 0.02. And then we also tested for her urine metabolites of paradichlorobenzene, which is 2,5-dichlorophenol, and that was also elevated too. So she was treated kind of supportively, and was eventually discharged. And unfortunately, she was readmitted a couple of weeks after discharge with mutism, and then she ended up passing away several weeks later. She just had progressive neurologic decline, and decreased sensorium. And she did undergo biopsy, and on autopsy, the coroner saw demyelinization of the white matter of the brain with vascularization, pale substantia nigra, and diffuse brain edema. So let's talk a little bit about what this entity is and what she was consuming. So paradichlorobenzene is an aromatic compound that's commonly found in certain types of insecticides, like mothballs, but it's also found in toilet bowl deodorizer and cleaner. It's been ingested by people because of either it has like a pleasurable odor, or in this situation, this patient's case, and in a lot of the published literature, is a female patient who has pica from iron deficiency anemia, and so there's a craving to consume this substance, the toilet bowl deodorizer, the mothballs, because of pica. But it can also be uh, consumed, I guess, in a different manner. It can be inhaled, or there's also powder forms, and there have been some, at least one case report of prolonged skin exposure where it's like sprinkled as a powder into the patient's undergarments, and then they get increased systemic absorption and toxicity. So paradichlorobenzene toxicity results in this kind of triad of neuropsychiatric impairment, whether that's altered mental status, ataxia, rigidity, hyperreflexia, seizures. Um, this patient had mutism, had sort of childlike behaviors. And then the second part of the triad is this ichthyosiform skin eruption with these kind of prominent sort of hair follicles that are hyperkeratotic. And then the third part of the triad is malodor, because it is an aromatic, volatile compound. And so it's sort of emitted from the breath through the body odor. And they have this kind of abnormal breath and body odor as a result. So this isn't my patient, but another patient published in the literature of paradichlorobenzene-induced cutaneous ichthyosis. And ichthyos just is Greek for fish, so fish scale-like skin is what ichthyosis means. So she has this kind of hyperkeratotic, perifollicular, thickened skin, kind of on the upper arms and chest area. Here's another case report as well. This kind of thickens ichthyotic skin on the antecubital fossa and forearms, and then on the knees of this patient. Um, CNS toxicity, you can see sort of various different findings on MRI, but it is characterized by demyelination and leukoencephalopathy. And what can happen is that because this is a lipophilic compound, it's stored in adipose. And if the patient goes through a starvation phase, then that stored aromatic paradichlorobenzene that's stored in the fat can sort of be released into the circulation and can cause like sort of recrudescence or exacerbation of their toxicity, even without ingesting it. And that's a process known as coasting. So for treatment, we don't really have any effective treatments. We know want to stop ingestion, and we want to stop paradichlorobenzene exposure, offering supportive care, offering sort of skin-directed therapies, and then potentially like monitoring these paradichlorobenzene levels or its metabolites just to make sure that the patient is adequately reducing their levels over time and not having a relapse. So let's kind of summarize what we talked about. So first case was acute bullous iododerma, rapidly progressive mucocutaneous blistering eruption following iodine exposure, especially in patients with impaired renal clearance. So stop the iodine, give them steroids, try to clear the iodine from their system. If they're on dialysis, maybe a push for hemodialysis and ultrafiltration. Our second case was pancreatic panniculitis. Remember, that's where you have these tender, sometimes draining, ulcerating nodules with histopathology showing ghost cells. And then they have this kind of liquid, turbid joint effusion. So it can be seen in acute or chronic pancreatitis, and it can be perineoplastic in malignancies, specifically acinar cell carcinoma. Our third case was thrombotic vasculopathy and ulcerative colitis. So rapidly progressive retiform purpura due to a hypercoagulable state, maybe from enteric antithrombin 3 losses through an impaired gut. And even if they're having hematochezia, you should still anticoagulate these patients despite their initial bleeding risk, and then control the underlying inflammatory bowel disease. And then the fourth and final case that we talked about today was paradichlorobenzene toxicity. So remember that with the triad of neuropsychiatric changes, ichthyosiform skin eruption, and then strong oral and body malodor. So think about, ingestion, especially in iron deficiency anemia and pica, or in patients with underlying psychiatric disease, and think about testing for this compound. All right, so those were our takeaways and our learning objectives. Hopefully we achieved all of these. And these are my references. And I thank you so much for your attention.
Thank you so much, Dr. Cheeley. Again, I always learn so much from you. Just really, really incredible presentations. And I really appreciate your description of, sort of the pathophysiology from the microscope up. Uh, what questions do we have from our team? From Grady for case 3, do these patients also present with other sites of thrombosis like PE or DVT? Or is this process selective for skin manifestations? Thank you for this great talk.
Yeah, great question. So we just saw the skin infarction. We didn't really see visceral infarction. She was pan scan, had a trans esophageal echo, didn't see any visceral thrombosis. And in the cases published as well, which there's not a lot, we didn't see any visceral thrombus either.
And do those patients typically end up on lifelong empiric anticoagulation, or is there a set duration recommended?
Yeah, great question. Again, sort of art of medicine. With this patient in particular that I presented, once her UC was controlled, then theoretically her hypercoagulable state would be better controlled as well. Again, we suspect that there's enteric losses of antithrombin 3 through kind of a defective gut barrier. And so once that's controlled, then the patient was able to come off of anticoagulation. But she was anticoagulated for a couple of months with enoxaparin and then to apixaban. And then her UC was under good control with infliximab, and she was able to come off of anticoagulation and didn't have any recrudescence of her thrombotic vasculopathy.
Question from the VA. Would renal replacement therapy have any utility for clearance of the dichlorobenzene?
Yeah, great question. I don't think it would because it is lipophilic, so it's stored in the fat rather than being, albumin bound or sort of in the circulation so much. That hasn't been described in the literature. I think Lauren Gensler and some of the MedDerm residents and some other medical students published a case series or kind of a review of the literature and a case report. I think they found like maybe 18 patients that are described in the literature with paradichlorobenzene toxicity. And I don't believe any of them were dialyzed. I don't know that it's dialyzable.
What other questions we have from our team? Dr. Bussey Jones shared that case report and systematic review. Excellent.
I had a case or I had a question up top. At what stage of CKD should we worry about acute bullous iododerma? Um, Great question. This is a rare condition. Not a lot of cases reported in the literature. I've seen 4 so far. Um, but I don't know that there's like a set cutoff GFR, basically is the short answer. But usually these patients have at least CKD3 that I've seen, CKD3 or worse.
All right. Well, with that, thanks y'all for being here. Thank you again to Dr. Cheeley for this incredible talk. And we look forward to seeing y'all next week. All right. Bye, everyone.
Thank you.